Hi there, welcome back. Thank you so much to Nikki and Louise for sharing their interview with us. And I hope you've all managed to take a quick cup of tea. For those of you who don't know me, my name is Carolyn McVeigh. I'm the mesothelioma CNS based in Glasgow and the CNS in Scotland. The next session today focuses on 3 recent surveys that have been conducted across the UK, and thank you to Rocket Medical for sponsoring the session, and indeed to everyone who's sponsored so far today. As before, after all 3 speakers have spoken, there will be time for questions. If you could just pop your questions on the chat function, I'll take them and put them to the panel at the end. His colleague Lorraine Creech, she's head of nursing with Mesothelioma UK, and she's going to speak about the Mesothelioma Outcomes Research and Experience Survey, the MESO-MORE study. This is a large study looking at patient experience and covering clinical circumstance, experience of care and quality of life. Thank you so much, Lorraine, for agreeing to speak to us today.
Thank you. Thank you for inviting me to speak about the MORE survey. Just a little bit forward on my clicker there. So thank you for inviting me. I hope that you find this informative today, talking about the Mesothelioma Outcomes Research Experience Survey. Reposition myself to see the slides, which are rather small for me. I'm going to pass through this slide because this is really just an update on Mesothelioma UK. As you can see, the MORE survey was a survey conducted in the first half, actually, of 2019. So that was completing around about the summer of last year and took us some time to report on. It was Mesothelioma UK's second large-scale survey, really comprehensively capturing real-world experience of patients from diagnosis and through treatment and care. Moving on then. The questionnaire was divided into 3 sections, as you can see. One was the patient experience of care and treatment. Secondly was a quality of life assessment tool, which was the EQ5DL. And thirdly, the individual clinical management of mesothelioma. Now, the survey was registered with each NHS trust via the mesothelioma nurse with the clinical audit department in that trust. And patients were able to access the survey via a tablet, via a web mesothelioma website, or in a paper survey. The clinical management survey, which was section 3, had to be validated by a CNS, and all the data was anonymous. So this is just a picture to show you where the 28 nurses we have to date are based across the UK, very much in a hub and spoke across Wales. But I'm very glad to say that we now have a hub and spoke across Scotland, and 2 posts are awaiting in recruitment for Essex and Edinburgh. So the patients were recruited, and I do want to stress it is a survey, and they learnt about the MORE survey from other patients, from the CNS, from support groups, from asbestos support groups, and from Mesothelioma UK via social media. Now, we had in total 503 responders. We actually had more responders than that, but we could only validate 503. And I'm very glad to say that of those numbers, there was 32 Scottish responders. I just want to make clear as we embark on the results that this was a survey, so it's not like the hard and fast data that we've been delivered from Phil and Rocco and Anna. So it is a survey answered by the patients, and it's the patient's responses. So as you can see here that we had 289 patients who were over 70 in the whole of the survey, and in Scotland was 19 of those patients. Also, this was by gender. Of the 32, 2 were female and 30 were male. As you can see here, there's no surprises here in the number of patients by site of diagnosis with left pleural and right pleural, the right pleural being slightly larger number, 2 peritoneal and 1 who did not identify the site of disease. Looking here, you can see the slides are very, very small for me, guys, in the events team. So I'm just relying on paper copies next to me as well. But as you can see on tissue diagnosis, that we had 84% of Scottish patients had epithelioid, 3% were sarcomatoid, and 13% were unspecified. Now, this only really differed with the national data. In the national data, we did have some mixed and biphasic patients. Clicker's gone to sleep on me here. If you see there, that's great. Thank you very much, guys. That's much better for me. This slide just shows the complexity of the number of investigations that were undertaken and what the patients go through to actually get through what we hope will be a tissue diagnosis. So we looked at occupation and we looked at the exposure. In Scotland, we had 2 electricians, 3 engineers, 4 carpenters, 1 lagger and 1 plumber. And interestingly, in Scotland, we had 1 teacher. Sadly, 8 patients left this survey blank and 8 patients reported being of other professions. So it did leave a little bit of a gap there in occupation and exposure. Now, moving on to the data that we had, which we class this as real world data because it is obviously from the patients. And on these slides, you will see the national data alongside the local data for Scotland. So we looked at patients who had attended the GP 5 or more times before referral, and that was 2 of the responders in Scotland. We looked at those who had attended hospital 20 or more times over the last year, and that was 6 of the 31 responders in Scotland. Those who'd been admitted to hospital 5 times or more in the last year was 2, and those who had had more than 3 CT scans in the last year was, as you can see, 13. So moving on, we looked at managing the symptoms. 18 of the 31 responders had experienced pain. So 58% experienced pain, 53% experienced breathlessness, 61% experienced fatigue, and 58% experienced cough. Now, this slide shows the experience and how the patients identified their experience in what had been done for them to help them in as much as possibly could by their doctors and nurses. So these results are based on those patients who answered yes, and yes, they did to some extent. So 94% thought that their doctor and their nurse had done everything they could do to help with pain. 88% thought that everything had been done to help with breathlessness, 74% everything to be done regarding fatigue, and 56% everything that could be done regarding cough. Not understandably, with cough being the more difficult symptom, perhaps, as we would say, to help with. So moving on to managing the pleural symptoms. Again, of those patients that answered this question, 24% had had pleural fluid drained more than 5 times. 50% were offered an indwelling drain, and 19% actually had an indwelling drain. Moving on to look at communication and support. 25% felt that they had been told their diagnosis in a way where it could have been delivered more sensitively. 6% had received some support regarding end-of-life planning, and 19% had received information regarding the role of the Procurator Fiscal. Moving on to treatment, 66% of responders had had chemotherapy, 6% of responders had had immunotherapy, 6% of responders had had radiotherapy, and none of the responders had undergone 3 lines of systemic treatment. Looking at surgery, as I said, remember this is a survey, very much a taught, I think, with Rocco's data earlier. Those who had had surgery were 3 of the 32 responders, which accounted for 9%. And those who had had a surgical biopsy were 14 of the responders, which accounted for 44%. This is just another slide to show the amount of and the way that the treatment had been given. And you can see that 3 had not had any treatment at all. Moving on to trials, which was very interesting, reflecting on our earlier sessions. Of those that had had clinical trials discussed with them, 38% had had clinical trials discussed at the time of diagnosis, 16% had had trials discussed during their treatment, and of those that had been enrolled in a clinical trial was 28%. So, bringing some of these to conclusions, I think we can see that Scottish patients had less visits, being at 19% versus 26% of the national cohort, and less CT scans at 41% versus 64%. 24% of Scottish patients had had fluid drained 5 times or more versus 16% in the national cohort. However, 50% were offered an interpleural drain versus 31% nationally, and 19% versus 13% had actually had an interpleural drain. 25% of patients felt their diagnosis could have been delivered more sensitively. Perhaps a reflection back to what Julie was saying earlier, but I think we've massively moved on from then. Regarding treatment in Scotland, 66% had chemo versus 76% on the national cohort, 6% versus 11% on immunotherapy, and 6% versus 9% on radiotherapy. So very much a muchness there, I think we can say. If we're looking at surgical diagnostic procedures, 44% in Scotland versus 40% in the main cohort, in the national cohort, and resection was 9% versus 17%. Again, remember please that this is patients who took part in the survey. For Scottish patients entered into clinical trials, it was 28% versus 31% nationally. And 19% of patients were informed of the Procurator Fiscal, which was less than the 27% in the national cohort who were informed about the role of the coroner. You may want to tease out some differences there, which I've reflected back on our previous sessions earlier. And for end-of-life planning, it was 6%, or support towards end-of-life planning seemed to be given by the doctor or the nurse. It was 6% versus 9% in the national cohort. So, going forward nationally, we need to do some further work on subgroup analysis of the EQ5D5L. What we do want to do is take the MORE survey forward onto a digital platform. We're doing some work along the roads of this called Mesodax, and we would like that to be integrated into the National Mesothelioma Audit. So this would be where patients were consented to fill in data at a period that was fitting to them, maybe monthly, maybe 3 monthly, on their treatment, on their burden of disease, on quality of life survey. And then we would have information going forward to really monitor our patients on a very large scale. So looking at our findings from Scotland, there appeared to be less hospital visits and less CT scans within the last year. That may be good, that may be bad, very much up for discussion in the time of COVID. And I think if we'd have been doing the survey this year, obviously that question would have probably been blown out of the water. Pleural effusion management in Scotland, it seemed as if patients were more likely to have an interpleural catheter or an interpleural drain going through the cohort that we spoke of during the time. It appears that less patients in Scotland having surgery. Rocco's data obviously doesn't reflect that, and so that's an important point to establish. And I think across the board we need to improve communication and end-of-life care planning and support for our patients. Sorry, my clicker keeps timing out on me. So here now we have just an image of how we would like to take a platform forward, a digital platform where patients could actually talk about their experience and give us some hard and fast real world data to go on with and manage their care. Just leaves me thanks to give some thanks and acknowledgements to all of the Mesothelioma UK Scottish CNS team who were really helpful, to Anna Morton, who did a brilliant job of disseminating and the survey to people and those that would be able to pass the survey on. I think that's another reflection of how this network has really taken off. I'd like to thank Alicia Riley and our ops team who prepared some of these slides for me, the asbestos support groups who helped out. Dash Global and SNAP Surveys were our partners. Bayer PLC gave an initial grant to get us started, and Euroqual for allowing us to use the EQ5D5L tool, which, as I say, we need to do more reporting on. But mainly, my thanks go to the patients and their families who let this survey, the MORE survey, take part. Thank you.
Thank you, Lorraine. Thank you for presenting all the data, but also thank you to Meso UK for collecting and sorting all of the data and the team that works with you. And we really appreciate the time that was spent over the last couple of weeks to pick out all the Scottish data. I know that there's been a lot of time and effort that's gone into that for today, so thank you so much. The next session is presented by Dr. Stephanie Ejejimemi, who is a research associate at the University of Sheffield. Steph's kindly agreed to speak about the gendered experience of mesothelioma study, or GEMS. This study really explored the experience of men and women with mesothelioma and their carers and family, as well as the staff who come into contact with them, and was aimed at understanding why any differences that were identified occurred. Thank you, Steph, for coming along today.
Hello, everybody. Thank you for having me here today. It's really lovely to be here. So today I'm going to present the gendered experience of mesothelioma study. Okay, so just to begin with, I'll give you a brief project overview. So our aim was to explore men and women's experiences of mesothelioma and to understand the similarities and differences that occur across the mesothelioma pathway from the perspective of patients. So it was a mixed method study. Stage 1 was the statistical analysis of national data. Stage 2 involved qualitative interviews and analysis. And then stage 3 involved testing the findings out with key stakeholders in focus groups. Okay, so HASAG, which is an asbestos support group from the south of England, very kindly provided us with a data set with cases from 2016, 17 and 18, and we had 1,177 mesothelioma cases. As you'd expect, the majority were from men, so 83% were from men and 18% were from women. So we found a few differences in the HASAG data set. Firstly, in age. So both men and women were mostly in the 71 to 80 age group at diagnosis. But what we found was that there were more young women in the cohort. So 5% of women were under the age of 50 compared to only 0.5% of men. Another interesting difference that we found was that fewer women had a next of kin, and also fewer women had a spouse or a partner. Now, when we were looking at types of mesothelioma, again, as we'd expect, we saw the majority of cases were pleural, but we did have 1% of cases that were peritoneal. And we found that women were more likely to have peritoneal. Okay, so we also explored compensation a little bit and what people felt about that. So proportion who said they were going to call a solicitor, and proportion who said who actually called a solicitor. So what this means is that the percentage of both men and women who are going to call a solicitor decreased over the 3 years, which surprised us. And the trend was the same for both men and women. And the number of men dropped by 12%, and for women it was 27%. So what that means is the percentage of women who seek legal advice dropped by nearly 20%. Now, so we spoke to our legal colleagues and kind of asked for some explanations of what might be going on there. And I think it's important to highlight that this is a relatively small data set. So these findings need to be tested out in a larger number of people. But yeah, we thought it was interesting. Okay, when we were looking at occupational risk, our findings were that the high-risk occupation for men was construction, carpentry, joiner, plumbers, electricians, all the things that I would say you commonly associate with asbestos exposure. But what we saw in the women was that the high-risk occupations were in administration, teaching, healthcare services. So I think it's important to highlight that we might need to look at risk, occupational risk in different ways for men and women. Okay, and then we also looked at the industrial injuries benefit. We missed out a word there. So we found that 11.6% of women did not receive the IIDB award compared to only 3% of men. And when we measured time from diagnosis to IIDB award, we found that the median time for men was shorter than for women. So women were taking longer to be awarded their award, their benefit. So now in stage 2, we interviewed 11 women and 13 men who were kind enough to participate, and we're just really grateful because Meso UK asbestos support groups were absolutely fantastic in helping us recruit to this study. So we had a range of ages. Well, we tried to get as much diversity as possible. So our age range was between 31 to 79 years of age. We had a range of living circumstances. We did manage to find 2 Scottish participants. The length of time living with mesothelioma was between 5 months to over 5 years, and we had a range of occupations. So the first key finding I'd like to talk about is that obviously a diagnosis of mesothelioma was absolutely devastating, and that always comes across in any interview that we do. But what was interesting was that men and women were both practical at diagnosis, but the way in which they enacted that practicality differed. So as you can see, Amy here, sorry, I should highlight we're using all pseudonyms. So Amy here says, you know, the first thing she did was to come home, chuck everything away, because her idea was that men don't wash net curtains. And we did see this in the women's interviews, that the domestic sphere and making sure that the family would be okay in terms of the running of the household, domestic chores, and emotional management also was taken care of. And what we saw in the men's interviews was it tended to be about financial management and the paperwork. So what Ivan did was to put all his affairs in order so that he didn't have to leave his wife with a heap of stuff to do, as he said. So control and treatment was another interesting one, particularly around treatment and trials decisions. So again, we've got Ivan there saying, I'll be telling them to stick the chemo where the sun doesn't shine. So the way in which the men spoke about their decisions was a lot more assertive and decisive, even if later on, as was the case in Ivan, they said, actually, I do want the chemo. And women tended to go for the, I'm not really sure, I'm not very good at making decisions. And it was just a very different way of expressing themselves, which, you know, as healthcare professionals, we need to be aware of. So when it came to impact on family, I've got 2 quotes from women here, because what really came across was that emotional burden, the emotional management. There Kath is saying she wasn't sure about going on a trial because she had caring commitments for her husband. And then Grace there was, you know, I'm not sure when I should ask my partner to come and visit me because I don't want to have a bad impact on his mental health, on his anxiety. And so that emotional aspect was really there in the women's accounts, whereas with the men, it was all about the financial well-being of the family. Risk perception. So although we were studying gender, there was also something about the occupations people worked in. So there you've got Fred at diagnosis. His feeling was a sense of inevitability. You know, he had friends who had asbestos related diseases or who had died of asbestos related diseases. So at diagnosis, you know, devastating, yes, but not really a surprise. Whereas for women, especially those who hadn't worked anywhere near asbestos or had partners or husbands or fathers who had worked in asbestos industries, you know, Fiona thought, what a stupid question to be asked, because asbestos related diseases weren't even on their radar. So seeking compensation, this was another interesting one, because you've got Irene there who wasn't 100% convinced. Women seemed a bit reticent, a bit reluctant to pursue compensation, or at least the women we interviewed. So that aligned with what we found in the numbers data and the quantitative data. And then Ivan there is saying, I deserve that and I should have that. So there was definitely a sense of entitlement for the men, but that entitlement was born out of a desire to look after their family and provide for their families. Okay, so stage 3 kind of got cut short because of COVID, but we did manage to speak to a group of MESA UK nurses just to test out our findings and get their thoughts on that. We have done some dissemination. This also counts, so I'm really happy to be here. So important points from the data is that the importance of a sense of control at diagnosis may differ between men and women, and this difference may have implications for the delivery of healthcare. And women and men may have different priorities during their mesothelioma journeys. Women may lack awareness of the risk of exposure and asbestos-related diseases. The nature of exposure to asbestos may be quite different. Therefore, we need to consider occupational risk different for men and women. And women are less likely to seek compensation according to our data set. So this could be due to lower awareness amongst women and a higher sense of entitlement amongst men. So in terms of the next step, we've got a report due to launch. We've got a couple of publications that are, that we're preparing. And I think what we're doing is trying to kind of bring together quite a few studies that we're working on and develop that. So we've recently been awarded the Mesothelioma UK Research Centre. So that's due to launch on the 23rd of November, and it's going to be led by Professor Angela Todd and Dr. Claire Gardner. So our vision is to conduct a portfolio of robust and rigorous research with a reputation for excellence nationally and internationally. I've run out of time, I think, but I've just got a quick list of the projects that we're working on at the moment. So please do contact us for any research ideas. And we're running a research prioritization exercise. We really want kind of the lung cancer, the mesothelioma community to come together. That includes healthcare professionals, legal professionals, patients, carers, anybody who might be involved, to say what do you think is important to the patient and carer experience, how can we improve it, and then we're going to have a mailing list, so please do contact us if you want to be added to that mailing list. So lastly, just to say thank you for listening, and thank you to, of course, everybody who participated, to Mesothelioma UK and the others who funded us. So thank you.
Thanks, Steph. I think examining patient experience always helps to shape services and redesign, but I think this study in particular has a focus on how we act or speak to patients and the impact that we can have. So thank you so much for sharing your findings with us. I know it's given me a lot to think about, and I'm sure it will for everyone else. Finally, in this session, we've got Dr. Peter Allmark, who's also based in the University of Sheffield and is a senior research fellow there. Peter's kindly agreed to speak to us about the MAGS study, which has only very recently been published, and this is the Healthcare Staff Mesothelioma Asbestos Guidance Study, which was really aimed at developing a critical account of the experiences of presentation, diagnosis and treatment and care for healthcare staff who have mesothelioma. Thank you, Peter, for joining us today.
Thank you very much. That's my first slide. So I'm reporting on this project, which took the acronym MAGS. You can see it's concerned with healthcare staff. I'll see if my clicker works now. I need to. No. Can I have the next slide? Okay, so I'm getting an echo at the moment. Let's stop getting an echo now. So this report, it took the acronym MAGS, and that was because it was inspired by Dr. Mags Portman. You can see the front cover of our report there, and that's Mags Portman, who was a senior and kind of pioneering doctor in the area of HIV, who died of mesothelioma aged 44. And she'd been exposed to asbestos through her work as a doctor. And the report was published a couple of weeks ago now, and there's the link to it there. Lost my internet. So next slide, please. So the aim of this project was to look at the experiences of presentation, diagnosis, treatment and care for healthcare staff with mesothelioma, and it involved sort of three main stages. One was to review the literature to see what had already been said or researched in terms of healthcare workers and their experience. A second was a freedom of information request, which I'll come on to, and the third was a semi-structured interview with a number of former healthcare workers who had developed mesothelioma. Next slide, please. So in terms of how many NHS workers develop mesothelioma, we did this because there was the data that exists at the moment is based on this mesothelioma mortality by occupation, and in that document, the number of people with the number of healthcare professionals who've developed mesothelioma or who've died of mesothelioma is quite low, and that has kind of led to a conclusion in that report there that healthcare is a relatively safe place to work, safer than average place to work. It says similar things with regard to teachers as well, as a matter of interest, and mainly sticks to the idea that mesothelioma or asbestos is mainly of risk to those working in the traditional industries. And that didn't tally with experience of people, our awareness of Mags Portman, but also of quite a number of other people who worked with mesothelioma, including legal professionals who could see that there were more. Often they had more sort of healthcare workers on their own casebook than was sort of showing up in the official statistics. So we wanted to try and get a better idea of what the actual figures might be. And to do this, so next slide, please. We put in a freedom of information request. And this was the way we did with this. people who have developed asbestos, who have developed mesothelioma due to asbestos exposure, will often take legal action. As we saw in the last presentation, about 50 or 60% of people will probably take legal action against their employers with a view to showing that they were negligently exposed to asbestos at work. So we asked the NHS Resolution, which is the body that deals with legal claims, how many current or former NHS employees had sued the NHS because they believed they had developed mesothelioma due to asbestos exposure at work. And you can see on the figures there, the sort of claims starting in 2004 and then climbing pretty steadily, with one particularly higher year in 2013-14, climbing from about 38 to last year 148. So these are all people who worked in the NHS and who have developed mesothelioma and believe that it was due to asbestos exposure at work. Now, if we can, if we have the next slide, if you compare the data from the ONS with this data, the time figure period isn't exactly the same, but between 2002 and 15, there were 177 deaths recorded of NHS professionals in the ONS data. And at the same time, there were 961 claims made against the NHS. Not all of those were successful because it's very hard to show that there's been negligence. It's not hard to show that there's asbestos in hospitals because almost all hospitals have got asbestos. What's hard to show is that your mesothelioma developed because of negligence with regard to that. But about half of these claims were successful. The other half were nonetheless people with mesothelioma who'd worked in the NHS. And remember, this understates the number of cases because, as we've seen from the previous presentation, not everyone makes a claim. The other thing about it was the rates of female death and claim with NHS staff are higher than male, which is an unusual pattern in mesothelioma statistics, but something that Steph was sort of alluding to in her presentation. And as we can see, the rate of claims is increasing. And one of the things that's sort of suggested in the literature is that there may be a third wave, what they're calling a third wave of deaths due to asbestos or of mesothelioma due to asbestos, where it started in mining, then moved into the sort of the industries where asbestos was manufactured and then used. And that we now may see a sort of peaking of mesothelioma in areas where asbestos is still present, such as schools, such as hospitals. Certainly the rates are not going down in the way that was predicted by the ONS a few years ago. They haven't given us the breakdown by occupation, so we don't know how many of these 961 were professional or ancillary staff. And we've requested that data, but been turned down so far. We're still kind of still asking that one. So that was one part of the study, but basically showed that there's probably a lot more mesothelioma around in the NHS, amongst NHS workers, than is suggested by the ONS data. We also, next slide, please. We also looked at the experiences of healthcare workers with mesothelioma. And in the literature, we only got, there's only data from healthcare professionals, and it's mainly from doctors, some from nurses, and a little bit from dentists. So there's no research that's looked at the experience of cleaners, porters, people working in the laundry and so on, where we suspect some of these cases are coming from. The lawyers know that that's where they're coming from, but there's no literature on that. And similarly, when we did our interviews, we actually only found nurses and doctors. We didn't manage to find anyone from any of the non-professional areas. What they suggested was the physical symptoms are pretty much the same. So things like pain, nausea, and breathlessness, as we saw in the first presentation. For some of the professionals, the meaning of these symptoms is different. Their awareness of what their significance is different, and in that sense, that there may be a stronger emotional reaction to those symptoms than others might have. So there tended to be quite strong emotional reactions to the diagnosis, exacerbated by those who did have knowledge of the condition. And actually, with that, a sort of a disappointment, or sometimes even an anger, that they had been working in healthcare and had been exposed to danger in those areas, a knowledge that that's probably where they got it from. There's a sort of loss of role that you see in doctors and nurses who suddenly become patients. It's very difficult for them. It's also difficult for their colleagues, and there were some examples of poor communication and poor care. And I do recommend that those of you who haven't looked at there's a YouTube video of Kieran Sweeney and his experience of care and the problems with communication, terrible communication sometimes, that he experienced as a doctor with mesothelioma. I do recommend that you have a look at that. So there's a lot more detail in our report. Next slide, please. We make a number of recommendations, and you can probably divide them into those sort of three categories. Some of them are to do with monitoring, sort of following other groups like Meso UK, and I think it's Action on Asbestos Awareness, or awareness on asbestos awareness. But the idea of better monitoring, the current guidelines on monitoring are flawed and dated, really, and they're not in line with best practice in Europe. We're suggesting, so that's the sort of improved management. Also suggesting sort of education of management and staff as part of mandatory training. In terms of care, one of the problems that was noted was that people who were formerly healthcare professionals sometimes get treated as though they're still colleagues in their own care rather than as patients, and some of the way they were, some of the sort of the way they were given information could often be quite brutal. So again, we have a number of other recommendations, but I sort of just picked those out. I think that's my last slide. Is there one more? So, no more slides, so it's not going anywhere. Okay, so yeah, so obviously there's a big sort of thank you to all those who took part. It was I really enjoyed doing the interviews. The participants were great, but it's those were the sort of recommendations from our report, or some of them. Thank you.
Thank you. I should have said at the start that these studies are available if you wanted to read more about them. If you go to the Mesothelioma UK website, you can get access and get a bit more information. I appreciate that 7 or 8 minutes is not nearly long enough to present all this information. We are running a little bit behind, but we do have time for a few questions. At the end of the questions, we're going to take just 2 or 3 minutes to let folk readjust, go to the toilet, top up their tea or whatever, before the final session for today. But if we could perhaps move on to the questions that have come through, that would be grand. That's okay. So I have a couple here. Lorraine, could I put a couple of questions to you, please, first? Sorry.
Yes, certainly.
So you mentioned the digital platform, which is, going to be an amazing asset for patients and to gather information about patient experience kind of going forward. The question that's been asked is if there are any plans to include any in a section for carers or family experience.
Not as yet, but it is. I mean, this is very much in its infancy, and it could be. But whether that would dilute the findings, the whole reasoning for MesoDAX, as we're calling it at the moment, is to have this digital platform, as I say, where the patient is enrolled in clinic. Start off, that may be wherever they are on the disease trajectory, but hopefully going forward it would come from diagnosis. So the patients would be able to comment probably about a monthly or a 3 monthly gap to say about their treatment they were having, or how they were side effects they were having, and how they were being managed, and very much bringing that real world data of the burden of mesothelioma alongside the clinical management. So at the moment, it's we're lining that up and working on that for patients. Very much in its infancy, as I say, but at the moment it's for patients.
Yeah, and the other question we wanted to ask is, over what period of time, I mean, I know the answer to this, but I'll put it to you, over what period of time the Meso-More information was gathered. I think with the advent of the Scottish network, it would be good to know at what point in the network that information was gathered, so that perhaps as QPIs come in and things change, we could, you know, redo the survey and see hopefully what improvements have been made.
Exactly. It was from January to June in 2019 initially, and then we extended it to August to try and reach that 500 number, which we were aiming for, to have a really good cohort of patients. And 503 is an amazing number across the UK. It's taken us a while to get to the report. The report has been technically difficult to pull together, but what it does give us at Mesothelioma UK is the ability now to disseminate that information with every region, such as Scotland, every Cancer Alliance across England. That's where we are at the moment. But obviously, we know now that it is a little bit of historical data, but nevertheless, I think because it has come from the patients themselves, it's very rich data to have.
There's a question that's come in now for Peter, asking if healthcare workers are more likely to seek compensation, presumably, than non-healthcare workers, and also, do you have an idea if healthcare workers are diagnosed at an earlier age?
So, sorry, can you repeat the first bit of that question?
Sure. So really what's been asked is if healthcare workers are more likely to seek compensation, and also whether in general healthcare workers are diagnosed at an earlier age. Right, okay. The first bit of the question is, I mean, actually to both of those is probably I don't have enough, I don't have that sort of that data. However, I think it's unlikely that all healthcare workers are likely to seek compensation. There's certainly, even amongst the small numbers I interviewed, there were nurses who had gone to lawyers and been told that they didn't have a case. Mm-hmm. So it wouldn't even have got to the point of approaching NHS resolution. The legal process involves lawyers looking at your case and an insurance company deciding whether you've got a 50% or better than 50% chance of winning that case. Well, if you're a nurse who's worked in several different areas, actually pinning down one authority or one trust as being negligent in their management of asbestos is really quite hard to do. So I think I doubt that they're more likely to, because I think it's quite difficult to do. I would have thought you know, like my stepfather was a builder, and he, you know, when he developed mesothelioma, you know, everyone was onto him straight away. The lawyers were onto him straight away, and it was a very smooth path. I should think it's probably less likely amongst NHS workers. In terms of age, I'm not sure. I imagine they're older.
the likelihood is that they've been exposed to smaller amounts of asbestos, and that this has manifested later in life. And that may be one of the reasons that the ONS data is so different to the data that we found through the Freedom of Information requests. That after the age of 75, they don't even record what job you had previously, so that all of that goes missing. But I would have thought they were probably on the older side, but I don't have the data to support that.
Okay. I do wonder if there's a sort of reluctance amongst some healthcare workers to seek compensation from the NHS just because they know there's a sort of, I don't know, a finite supply of money, and there's always that.
There was at least one person said that to me.
Yeah. There's clearly an awful lot of good work happening in Sheffield at the moment. I just wonder, Steph, are there plans for, is there anything recruiting at the moment? Is there anything, you've got a wide audience here that you could speak to if there's anything that you would like to sort of highlight?
Thank you. Yes, so we've got two sort of, well, one's more of a study and one's the prioritisation exercise. So the study that we're recruiting to at the moment is for one of our PhD students, Virginia Sherborne. I don't know if anybody knows of any patients who are ex-military. We're trying to interview carers, family members, friends of ex-military patients. So if anybody knows of anybody, please get in contact with Mesothelioma UK for more information. They've got all the information, so that would be fab. And the only other thing is that what I mentioned in the presentation, the research prioritisation exercise. I know the mesothelioma community is really enthusiastic, and everybody's always got so many ideas. It's such a shame we can't do these things in person at the moment. But if anybody does have any ideas that you think, this would be a great idea for patient care experience research, again, get in touch with Mesothelioma UK.
Thank you. Does anyone else want to add anything? Or
Can I just say, just alongside that, other research projects in the pipeline is looking at the difference the Mesothelioma UK makes to palliative care of patients, and what just actually, probably on a little bit of the back of Respect Meso, what does the mesothelioma nurse bring to the patient to make their care different? And also we very much like to move forward and look a little bit at peritoneal mesothelioma, because patients often come down, as we know, down a completely different pathway and are not directed to support. A little bit back to what Julie was saying this morning, the early part of the session is, where do they go for support? And so that's signposting to that, but on behalf of the nurses and the patients.
Peter, did you want to add something?
Yeah, I've got a request as well. I'm looking at teachers at the moment, or education workers. So again, it's the same thing. It's teachers, but also anyone who's worked in schools. So caretakers, cleaners, and so on. At the moment, we're not looking to recruit people to interview, but I am looking for articles that tell people's stories. So if anyone's, I'm struggling in the academic literature to find much that says anything about sort of education workers and their experience of mesothelioma. So if people know of sort of news articles or any other literature, kind of unofficial literature, that would be, I'd like to see that. That would be nice.
Brilliant. Thank you. And thank you again, all of you, for joining us today.